Hey guys, good morning. Kind of tail end of the morning, I suppose. Um, I thank you for joining me. I thought I would introduce myself because I am not giving a talk on the other side. I know a couple of you, but not everyone. I am B. Razzo. I am one of the two myeloma-focused faculty at Jefferson in Center City, in the Center City group. We collaborate with all the other Jefferson satellite groups, and I have been there for a year. Previously was with the Penn group, so everyone you heard speak so far, I guess with the exception of Dr. Carr, who I also know and have worked with in other contexts, have been my mentors, and so kind of special to see them talk in this different setting, and they are incredibly kind of the reason I went into this as a field. I've been practicing for a year now at Jefferson, and am happy to share with you guys a little bit of kind of how we think through everything. So really, you've heard so much information this morning that I thought this would be really just a reflective kind of interactive time in just thinking of how this applies to you, or barriers or challenges you encounter in terms of navigating all of this complexity. I welcome kind of feedback, ideas, and what other types of resources or connections would be helpful. So really, this is a time for you. I don't really want to overload with more information. I think sometimes it's helpful to step back and think of more overarching principles and frameworks to guide some questions. So maybe I could spend like 3-5 minutes talking a little bit about kind of the tree of diagnoses, kind of within myeloma and even before, what we call precursor conditions that Dr. Vogel mentioned a little bit. And so all of the clinical trials that exist in this space are very specific to where you are in your diagnosis, and kind of response to prior treatments. And so I thought I would briefly run through kind of, really it's an overview because you would have heard snippets of that today, but just talk a little bit about the range of diagnoses we think through, and then a little bit about how clinical trials are kind of split or structured or meant, because that's obviously kind of getting pairing your information with the legibility and the structure of the clinical trials is something that your physician can help provide, or CureHub can help kind of accelerate that. But when you're first discussing then a clinical trial, it's also very different if this is something like a phase 1 versus a phase 3. So I thought I'd briefly mention a little bit about what that means. I guess just not to call anyone out, but who here has either been discussed a clinical trial or participated in one? Anyone here? Okay, raise a few. Anything, and then you guys can tell me whatever else is helpful to hear. And yes.
I signed up to participate in one. Basically, we just talked over the phone as one of the students from the University of Penn. And she sent information online where I had to fill out pertinent information, and explained that sometime you can be accompanied by, I guess, like a monetary donation certain times for the period that you participate, but I haven't heard anything else since.
Absolutely. Thank you for sharing a little bit about your experience. I thought I would actually touch a little bit upon the kind of question of monetary or lack thereof in clinical trials. So thanks for bringing that up. So we can review a little bit of that and just mostly be a time of questions, and certainly comments in between, please do. And so I think you have we're supposed to talk a little bit about newly diagnosed, but just as a reminder in terms of the framing. So Multiple myeloma is when the cancerous plasma cell kind of becomes active to the point of causing a very specific set of symptoms, but patients may be diagnosed with a precancerous form of multiple myeloma that either kind of falls under the diagnosis of MGUS, so monoclonal gammopathy of undetermined significance. I think of that a little bit more kind of almost like a polyp, where there is an extra growth of a cell. It's there, but it's halted or it's not growing rapidly, so it's not causing symptoms, even if that abnormality is present. And so MGUS is kind of the polyp of plasma cells, where there is an increased amount of it. But for many, if not most people, it does not go on to become myeloma, even if, such as patients with more polyps, there is a greater risk of it becoming colon cancer. With MGUS, there is an increased risk of it becoming multiple myeloma, and therefore it is monitored for patients. And then the in-between kind of condition, a very broad set of diagnoses and risks, what we call smoldering multiple myeloma. So yes, there is an increased amount of those precancerous cells, increased amount of plasma cells, and right now they are not causing problems in anemia in the kidney and the bones, but there is overall an higher risk of developing myeloma than someone who falls under the MGUS category. Yes.
You mentioned polyps. We're talking, that's GI, polyps.
Yes.
And they can be detected in terms of having abnormal cells that could lead to multiple myeloma. Is that what I'm hearing?
Yes, tracing the analogy, just like you undergo a colonoscopy and a polyp is an abnormal growth of the cells that right now are not causing a problem but could go on to become the symptomatic cancer. That is kind of what MGUS is in analogy in comparison to multiple myeloma. That is the developed cancer form of what was at some point MGUS. In fact, everyone with multiple myeloma at some point had MGUS, even if that may not have been known.
I have a quick question. My husband was diagnosed with multiple myeloma. He was diagnosed because they found a lesion on his spine. Now, can the lesions develop like in the extremities, or is it really pretty much in the body,
It can develop anywhere.
So like if he's having trouble with his legs and things like that, it's probably worth investigating with another scan, perhaps? I mean, he's being treated, So.
Yeah. I guess a little hard to without knowing all the circumstances, but absolutely. Full body imaging is part of both the initial investigation for somebody with multiple myeloma and its follow-up. And certainly any symptom like that should be discussed with a physician.
I had kind of good luck, bad luck. I had some echocardiograms by my cardiologist, which were indicating an aneurysm. So he decided to do a CT scan. The cardiology part was okay, but they discovered a mass in my spine, which was good luck because I had no itching, no pain, nothing. So it was really good luck that they caught it at that time.
Yeah. No, and no, thank you for sharing. A lot of patients come to us with having either the bone lesion or the anemia or the kidney injury found kind of serendipitously before having more severe health changes and health complications, and we're glad. We're often really happy when that's the case for our patients, because then our thought behind treating is to treat before you have any long-lasting devastating health consequences.
I just had a question. Were you saying that the polyp is analogous to MGUS, or that it's a symptom that can indicate MGUS?
It's just the analogy I often trace in terms of how to explain or conceptualize and think of MGUS. Yeah.
I'd like to share. I didn't have a polyp or anything of that nature, but my health, one thing after another, and I broke my ankle and climbing the stairs, And I told the doctor, I said, you may not believe this. I said, but I broke my ankle. I didn't even fall. So the weight of my body must have, the bone must have like broke on its own because it was weak. She said, Mrs. Baxter, I'm going to do some research. One thing after another with you, I don't understand it. And it was. I mean, every time you look at it, I was at the doctor. And she came back with did the smoldering mode. She said, all these different things that are happening with your body. I didn't have any lesions or anything like that. And that's what she came up with, the smoldering mode. She was a smart doctor she was a resident from Jefferson.
Ah, nice. Yeah, yeah.
Yeah.
No, and I'm hearing a bit of a common thing, right? Even before getting to oncology care, having thoughtful, close general health care and thoughtful providers involved in your care is so important and very much our allies, because this is not a simple disorder at all. There are complications of therapy. Your other health problems remain active and can make treatment harder, and so it is a very multidisciplinary care and condition, absolutely.
We've got a question here.
Sure. I was diagnosed back in April, and it was just through a blood test. I had no symptoms. But before that, I ended up with a couple of autoimmune diseases. I ended up with colitis, and I ended up with PMR, maybe a year before. Is there any chance that this was brought on by the vaccine?
Oh. COVID vaccine, you asked specifically?
Yeah.
That's a tough question, and certainly one we are often asked about, both in the myeloma, patients with myeloma, certainly for patients with lymphoma, and one that understandably I think is a hard one to answer, because so many people have gotten the COVID vaccine, and many would have gone to develop multiple myeloma, lymphoma, or certainly other autoimmune disorders. I think, eventually we'll have more and more data to maybe suggest. We do know that there's a strong immune response to the COVID vaccine, and so I think we'll know more and more in the future, even though the data isn't quite out there yet. Maybe.
Again, about diagnosis, full body imaging, who qualifies? I mean, this is very extensive. It's not your first, choice in terms of, I would imagine, in terms of diagnosing. I know we get blood work, the polyp, all those other things. Who determines when and who qualifies for the full body imaging?
Yeah, great question. And so what we tend to think of in terms of full body imaging as myeloma physicians we have essentially 3 different types that are considered adequate, thorough, sensitive enough to really say, well, this patient who either has smoldering or MGUS or multiple myeloma, and we're really just trying to understand if there are any spots in the bones that are at risk for fractures, or that we want to make sure that throughout treatment remains a protected spot. And so that is a PET CT, a full body MRI, which is done a little bit less in the US for kind of various logistical reasons, but certainly still very good and used more in Europe. And then a full body low resolution CAT scan. All 3 are tests that anybody who has been diagnosed with smoldering multiple myeloma or multiple myeloma should undergo at the time of diagnosis. And then the kind of follow-up, repeating that on follow-up, is a little more controversial, but certainly may be considered every time there's a change in the disease, or at least annually. For people with MGUS, that's a little bit more nuanced of a consideration and a discussion. But right, these are tests that you might do just once you have gotten to the diagnosis. most patients with multiple myeloma, with smoldering or MGUS, those cancerous plasma cells release substances such as your immunoglobulin, the light chain, and so other than somebody who was already found to have a spot in the bone, the blood work is often something that kind of leads that trajectory to the diagnosis. Yes.
I just have a quick question about, is it in any way genetically passed on? We have 3 daughters and 4 grandchildren.
Yeah. Good question. This is a center. One of my colleagues is kind of a lot of studying in genetic susceptibility to blood cancers. Where this is better understood in some blood cancers more than others. Certainly not very well understood in multiple myeloma. The majority of cases are not genetically passed on or inherited. And so my general recommendation for patients is for their family members, their children, to just have regular, good, comprehensive care with their provider. But we do not have general screening recommendations for children. But there's certainly more to be understood about this, because we have had some patients who have become kind of clusters of cases, so siblings or other more immediate family members, where there's an unusually higher cases of either myeloma or lymphoma or just blood cancers in general. In that case, that's certainly a relevant thing to bring up to the provider and consider referral to a place that has more comprehensive genetic evaluation.
We go here, and then we all go to you.
I was having gastrointestinal issues where my gastro doctor did the colonoscopy and endoscopy, and I was diagnosed with amyloidosis, the AL type, in my gastrointestinal tract, of course. While I was in the hospital for 4 days, that's where they did the bone marrow, and they discovered that I had the multiple myeloma. So not only do I have the multiple myeloma, I also have the amyloidosis. So I am on maintenance therapy now, just monthly, with the Darzalex Faspro and the Revlimid, and that's all that I'm on. Whereas I don't need to have a stem cell transplant. I'm not a candidate because, again, I'm doing very well with my treatments. So there's other issues that can lead to the multiple myeloma.
Yes, absolutely. Yeah, thank you for adding. Not even though for many patients the protein made by these cells in and of itself is not harmful, it can be. And certainly one of the very harmful ways in which it can accumulate in organs is called amyloidosis. And when our patients have amyloidosis with multiple myeloma, or there's a case where you may not even have too much of those cells, but if it's toxic enough, then we need to treat. And really the mainstay for that is not only keeping it from causing the multiple myeloma set of problems, but keeping all organs that are involved with amyloid as safe as possible. Thanks for bringing that up.
Okay, so my question was, because my husband didn't know he had multiple myeloma until he had it, found it by accident. So there's like no testing for people right now, like with polyps, you can check a polyp to see if you have colon cancer. So there's nothing for multiple myeloma. So say if our daughter told her doctor, is there like a certain test or certain blood tests that they should be performing?
Yeah. No, the blood test that anyone with MGUS or myeloma gets is that usually we think of a set of 3 different blood studies. So that's the light chain, that's the SPEP that particularly captures an abnormal set of antibodies. We call that M-spike, and then the total amount of the antibodies. Those are simple tests that really any physician can order. So serum-free light chains. The light chains, yeah, we can review a little bit about what those are. Quantitative immunoglobulins, and then SPEP. SPEP short for serum electrophoresis, so a particular way of detecting, well, do you have just a normal range and distribution of antibodies, or is there a kind of blip in that curve that suggests that there's too much of a single abnormal antibody? And that is what 98% of people with multiple myeloma, the cells are producing that. So not everybody, rarely we will encounter someone with multiple myeloma that has totally normal blood tests, but it's just, still causing bone problems, anemia, but that's not most patients' experience. And so to Cindy's question about, well, should everyone be, should children be just getting these tests done? And this is not a general recommendation either for population-wide in terms of screening or for families, but can always be considered on a case-to-case basis along with the patient's primary care provider, knowing that person's family history. There are surrogates to this, so that's why I say just your annual blood work goes a long way for these patients. So if there is any anemia, if there are any low platelets, if the protein on your general chemistry panel. So these are things that many primary care physicians, if they're thoughtfully watching their patients' regular blood work, can use to then go up and order those follow-up tests. And so that's, I think, generally what children of patients should be getting checked as indicated by their primary physicians.
Hi. Specific to clinical trials, great to see HealthTree has a way to navigate and figure out what you may be available to take advantage of. However, when is the best time to start looking at clinical trials? If I'm theoretically in quote-unquote remission, then why would I should I be looking at clinical trials or wait until one of my therapies fails, one of my treatment fails, and then go to clinical trials? I'm just not quite sure how clinical trials are supposed to tie in to the journey.
I think perfect segue. I guess we were, what time is it? Meant to get into a little bit of that, which hopefully a few minutes. So clinical trials, right, just a broad umbrella term, meaning this is not the standard way that we do things. We want to try to make it better or understand it better, improve upon which it is done. Certainly when somebody has relapsed myeloma, even though you've heard of the great success story of many different new treatments, most patients are not getting cured. Unfortunately, myeloma still often relapses, and so clinical trials for relapsed multiple myeloma is a lot of what you would have heard there, right? Combinations of therapies, combinations of new drugs, and so it's a lot in the clinical trial space is geared towards that, but not the only setting in which clinical trials are offered or are done. In fact, at our center at Penn, we try to have at least a clinical trial option available throughout the multiple different phases of someone's care, because throughout smoldering to relapse myeloma, there is room for improvement, for better understanding of how we do things. And so, yes, a lot in the clinical trial space is for relapse disease, but for smoldering multiple myeloma, we have a study open. For newly diagnosed patients, we always try to have a study for patients who are intended to go through auto transplant, patients who might be older and where that is not favored. There are clinical trials for that. And so if you were someone who at the time of diagnosis this was discussed, then kind of would have considered, is that the right thing for me? But all throughout a patient's journey, we try to make clinical trials available, because that's just a broad way to say, well, we can do better. And many clinical trials are offering something that is in addition, but sometimes a clinical trial is actually not offering something. And so, for example, a trial we have open both at Jefferson as well as Penn that is seeing if one of the medicines that are used for relapsed refractory multiple myeloma, teclistamab, trying to better understand, well, do patients really need it to take it every week or every month until the myeloma starts growing again, or is it safe to take a break from it? And so this is something called a pragmatic clinical trial, where instead of just looking back at people and trying to understand how they did or how that went, when you organize the study and are proactive about looking at it in advance, that's a form of clinical trial to just better understand how things are done in a homogeneous and well-controlled manner. And so not answering your question too specifically, but just kind of alluding that this is a very broad term, and and I think the ultimate thing, I think, is exactly what you guys are doing. You're staying connected with each other, with different centers, different physicians, hearing different perspectives, and I think, right, that's fair game throughout your journey, but the exact time is very dependent on location, circumstances, treatment teams, and so I think a hard thing to answer specifically.
I think we have time for
We
one more
have, let's
question
see,
in this session.
2 more.
We do have another Q&A later today after lunch, and so hold your questions for that. But we have one more question here.
Yeah, so this is regarding the topic we discussed earlier regarding blood tests for kids. Maybe it's not something you can answer here, but I thought I'll ask anyway. I'm assuming this may not be covered by the insurance. Like it's not a standard of care, right? Like for blood testing, that's one thing. And an approximate range if we have to go do it by ourselves. And also, are there any places or organizations which will do that for us? We can sign up and do that, because I don't know the path, how to go about it.
Yeah, good question. I don't quite have the answer, certainly not of how much it would cost. It's very dependent on the patient and if insurance might cover. Mm-hmm.